Great. Thanks for that great introduction, Wendy, and wanted to especially thank Grace and the MRA for hosting this event and giving some of us who have been working in this field for roughly a quarter of a century to get to talk a little bit about the amazingly exciting explosion that's been happening literally over the last few years in immunotherapy, one that I think is really going to, over the next 10 to 15 years, continue to transform the outlooks for patients with advanced cancer. Those of us who have been working in this field for a long time have been doing so based on the very straightforward notion that, by all accounts, the immune system should be the perfect anti-cancer weapon. We know that cancers have distinct biochemical signatures secondary to mutations and epigenetic changes that make them look biochemically different from a normal cell. And the immune system, there is no system as well equipped as the immune system to really distinguish those differences. In particular, the T cells and also antibody-forming cells of the immune system can have huge numbers of receptors, literally in the 10 to the 18th to 10 to the 22nd. So that's a billion different receptors. This gives them an incredible versatility, and also it confers specificity to the immune system. So these receptors in the immune system can distinguish two molecules that are identical, save for the smallest organic difference, a methyl group, by recognition differences of 1,000-fold. There's absolutely no drug that can come close to doing what this receptor system in the immune system provides. The immune system has amazing weaponry to kill cells, because that's what, for example, T cells and natural killer cells need to do to get rid of virus-infected cells. There are, this is just a few of the weapons that they use, 12, 15, 20 different forms of weaponry to kill cells. And so any individual tumor cell would have an extremely difficult time. I'd argue it would be impossible for them to be able to develop resistance to all of these targeted killing mechanisms at the same time. And finally, the immune system has a very unique property called memory. Memory is why we can get a childhood vaccination when we're a few years old, and that vaccination will give us immune memory that will protect us from infection with the vaccinated virus or bacteria lifelong. And so likewise, what we'd like to be able to do with cancer immunotherapy is to be able to give that immunologic therapy, create a memory against the tumor that essentially lives and persists within that patient, that goes on to fight that battle long after we've actually stopped having to bring the patient back to the hospital and keep giving them therapies. And what you're going to hear is that this is actually now coming to fruition after many years from literally hundreds of investigators, laboratory and clinical, that have been developing this field. So when I was an oncology fellow about 25 or so years ago, we learned that there were three pillars of cancer treatment. Surgery, which first really developed in the 1900s, radiotherapy, which developed in the 1950s, and chemical therapies also developed around the 1950s. And things really hadn't changed for over half a century. And then it was really because of a few key events between 2011 and 2013 that this explosion occurred in which immunotherapy really has now become established as the fourth pillar for cancer treatment. And during this period of time, sort of like it's World Series time, you all probably remember the World Series when Reggie Jackson hit three home runs in the same game, or was it maybe four? But so this was a case where there were really 3 home runs, all within about a 3-year period from 2011 to 2013 in this field. One was the phase 3 results in melanoma for an antibody against an immune checkpoint called anti-CTLA-4, also known as ipilimumab or Yervoy. Also, some of the earlier but amazing results produced with antibodies against a different immune checkpoint, and you'll learn what checkpoints are in a moment, called anti-PD-1. And then in certain leukemias, the use of engineered T cells, again, small numbers of patients, but such dramatic results that these 3 events, all happening within about a 3-year period, created this explosion that brought immunotherapy onto the stage really as a fourth pillar. So what we're now learning is that the set of antibodies, and there are about 8 or so that have now gone into the clinic against either PD-1 or its partner PD-L1, as a group are turning out to be probably the most impactful cancer drugs in history. There are now 8 or 9 different cancer types in which there has been at least a 20% response rate demonstrated for monotherapy with these antibodies. I think it's conservatively fair to say that by 2025, over 70% of cancer patients will receive some sort of immunotherapy. And for those of us who are still working very actively in the field, we can see that 95% of immunotherapy's potential has not yet even been mined. So this is an area that is going to be evolving incredibly quickly, and it's also one that the FDA, pharma, all patient advocates need to really come together to understand this and help this field progress more quickly, because the capacity, the potential is so great that some of the old, slow paradigms for drug development really need to be thrown out the window so that these therapies can be developed much more quickly and be brought to patients much more quickly than has been the case in the past. So a couple slides of Immunology 101 primer. I should mention, by the way, that not only in the clinical community, but in the scientific community, this breakthrough for immunotherapy has been recognized. Science, which is one of the big journals, does a Breakthrough of the Year issue. It's their last issue of the year. In the past, they've had things like the sequencing of the human genome, the discovery of the Higgs boson, and whatnot. And so last year, 2013, the Breakthrough of the Year was, in fact, really given to our field of cancer immunotherapy because of these breakthroughs that have occurred. Okay, so the immune system. The immune system can be, it's an extremely well-developed system. It has many components that work together very effectively, that integrate together. And the 2 major arms of the immune system are the innate and the adaptive immune system, each of which have a lot of potential to be brought to bear in cancer. Innate responses are those responses that are very rapid. They're not quite so specific as adaptive responses. They're very critical for bacterial infections. They generally don't display memory, and there are a number of the subsets of white blood cells that you've probably heard about. Neutrophils, which are the major cell that you see in pus, macrophages, and natural killer cells. The adaptive arm of the immune response is somewhat slower to develop, but it's very highly specific. It's particularly critical for viruses, and also very central to tumors. It's the adaptive arm that gives you this phenomenon of immune memory. And the two major white blood cells that affect adaptive immunity are T lymphocytes and B cells, which essentially are the antibody-producing cells. Now, again, these two arms work together hand in hand to fight infections. They don't really work at cross purposes at all. And just to give you an example of how they would respond to an infected cell. So here you have a cell that's been, let's say, infected with a virus. And you can think of this as a tumor cell, in which for a virus-infected cell, it's the proteins that virus produces that the immune system uses to distinguish an infected cell from a non-infected cell. In the case of a tumor cell, it's all of the protein changes that result from all the mutations in the cancer cell, as well as genes in the cancer cell that are normally turned off in the normal cell counterparts, but because cancer cells are dysregulated in their gene expression, now will overexpress and turn on a lot of these genes that are normally turned off. So this schema that I'm going to show you with regard to how the immune system integrates to attack an infected cell is the same kind of thing that we're really pushing the immune system to do with a cancer cell. So the first thing that happens is that an infected cell sends out these so-called danger signals. Infected cells, just like cancer cells, are stressed cells. Stressed cells actually start secreting things that innate components of the immune system can recognize as dangerous. So they're the first the first white cells to actually kick in. And they can actually provide some direct killing effect on their own. But they also help then communicate with the adaptive part of the immune system. And that's through this very specialized cell called a dendritic cell, which can also become activated when there are these so-called danger signals. And also, as some of these infected cells break up and release viral antigens, or in the case of cancer, tumor antigens, those tumor antigens can actually be gobbled up by the dendritic cell, and then pieces of them can be presented on their surface on a molecular system called MHC. The human version is called HLA, and that's what actually triggers the T cell. Now, in addition to this first signal to the T cell, there are second signals that are called co-stimulatory signals that this dendritic cell is also specialized to give to this T cell. And it's this right mix of recognizing the antigen, which is really that piece of that virus or that tumor, plus co-stimulation that now activates this T cell and adaptive immunity. This generally takes about 2 to 3 days, as opposed to this process, which literally can occur within about 10 to 15 minutes. Now, the T cell, once activated, can actually go and add to the armamentarium by directly killing the infected cell. In fact, these activated T cells are oftentimes called killer T cells. But what they can also do is they can make signals that now activate B cells to produce antibodies that also can attach to components of that virus and help clear it as well. So this is, in many ways, like a war where you've got the Air Force, the Marines, the Army, the Navy, that when it's prosecuted properly, they're all working in concert in an integrated fashion. And the immune system is doing this all the time, at least once a week, and we generally don't even know it. It's happening. T cells can actually feed back and further amplify the effect of innate effectors. So this is this very, very integrated system. And what we're learning is that tumors can disable various elements of the system when they're growing to resist being naturally eliminated. And now that we're learning exactly the molecular mechanisms for how this system works, we can block those resistance mechanisms and essentially shift the balance to empower the patient's own immune system. And this sounded like fantasy, but it's really getting there. Now, the other thing you have to appreciate, there's another important component to how immune responses are regulated. We originally thought of the immune system in a linear fashion as an accelerator. If you had the antigen, this is the piece of the virus or the bacteria, the tumor, that with receptors the immune system can recognize with the right co-stimulatory signals that's pushing on the gas. You had this linear immune response that was generated. But about 25 years ago, basic immunologists began to realize that because the immune system can actually be very dangerous if it's not carefully regulated, dangerous to our cells, the immune system had to be regulated with brakes. So for every accelerator that pushes the immune system forward, that amplifies the immune system, there's a set of brakes. And so there are many brakes that turn off the immune system. And the analogy of driving a car is really, I think, quite apt. To drive a car properly, you need the steering wheel, but you need an accelerator and you need a brake. Now imagine a car where you had about 15 different accelerators and about 15 or 20 different brakes, and that's basically the immune system. And for different kinds of immune responses, and also, as it turns out, for different tumors, there are different accelerators and different brakes that seem to be operative. And this is part of the immunotherapist form of personalized medicine, is to figure out exactly for Mr. Smith's tumor which accelerators to push on, which brakes to disable, which are going to be different than Mrs. Jones's tumor. So that's one of really the frontiers that we're beginning to think about. The major approach to pushing on the accelerator to pushing anti-tumor immunity has been vaccines, but some of the biggest breakthroughs have been blocking these brakes or checkpoints, and we call that checkpoint blockade. And as you can imagine, some of the really exciting opportunities that are just now beginning to come into the clinic are combination approaches where vaccines together with checkpoint blockers are being used in combination. So the key is that for cancer, also chronic infection, generally T cell responses are hypoactive. Tolerance is really the operative state. And so for the treatment, we want to essentially enhance co-stimulation, but also block checkpoints. There are other immunologically mediated diseases that these insights are going to actually help us be able to treat much more effectively as well. So for autoimmune diseases, transplant rejection, their immune responses are hyperactive, and so the treatment is really to now block co-stimulatory pathways and actually engage checkpoints to basically turn the immune system down. And so one of the really exciting things for our field is that the cancer immunology and immunotherapy efforts that we're doing are actually providing a basis for therapies in the opposite direction, but using some of the same molecules and targets in the reverse or converse fashion to treat autoimmune disease and transplant rejection. So I mentioned to you roughly 10 or 15 accelerators, 10 or 15 brakes. These are some of the accelerators and brakes. The accelerators are the green arrow with a plus. The brakes are basically a red arrow with a minus that we've been able to discover through molecular biology at the basic level. And what I've circled here there are two of these targets, PD-1 and CTLA-4, for which blocking antibodies have been FDA approved. Anti-PD-1 just very recently in melanoma this past summer and fall. But some of these other guys are targets for which there are active clinical trials in progress, for which there are actually agents, most of them antibodies, that are in the clinic in early stage clinical trials as we speak, some of which are actually in combination. And there are a couple of other of these that within the next 1 to 2 years are going to further go into the clinic. Now, in some of these cases, blocking these inhibitory checkpoints has tumor specificity because they are selectively upregulated in the tumor. So the tumor has co-opted these natural mechanisms of immune regulation by which we protect ourselves from autoimmunity to actually protect itself from the patient's immune system going after and successfully attacking it. So for example, if you look at the major partner in solid malignancies, PD-L1, the partner for this inhibitory checkpoint receptor PD-1, and you look just for example in kidney cancer, here you have expression, the brown is positive in normal kidney, and you can see there's virtually no PD-L1 expressed in normal kidney, but these are two examples of kidney cancer where the expression is very highly elevated. So it turns out that in about 30 to 40% of cancers, a very diverse tumor type ranging from melanoma, kidney, lung, and all of these, there actually are these very different levels of expression here in the tumor. And so these kinds of differential levels of expression sort of tag these as very promising targets to block when we know that biologically they're immune checkpoints, they're brakes on the anti-tumor immune response. This was actually one of the very first patients, a melanoma patient treated with an anti-PD-1 antibody, and you can see the tremendous reduction in tumor size over a 3 to 4 month period. So what this is teaching us is that indeed patients do have circulating in their blood T cells, lymphocytes, components of the immune system that are there ready to and trying to attack and eliminate their tumor, save for the upregulated expression of these checkpoints that the tumors have used to develop immune resistance. And I have to say, when we started these trials, I would have never imagined that simply blocking just one of these checkpoints would have been sufficient. But in a number of cases, that's exactly what we saw. Blocking this just one checkpoint was sufficient to shift the balance basically in favor of the immune system, and then the battle ultimately completely shifts. This is an example of what one sees. This is called a spider plot, in which each one of these lines represents target metastatic tumor lesions that the radiologists measure. And this is looking at the change in their total volume with time of treatment. So treatment starts here at day 0, and so everything starts at 0. If the tumors progress through treatment, then these lines go up. If they decrease or regress, they go down. And there are a number of things that you can see. This is an example of nivolumab treatment, one of the anti-PD-1 antibodies in melanoma. And you can see that a lot of patients are getting either disease stabilization or regressions. Now, in most cases, the regressions are not considered complete responses because the radiologist says, well, I still see something on the CAT scan or on the X-ray. But what happens is that the responses tend to be very stable even after the antibody has been stopped. And so what this tells us is that what we're doing in these patients is shifting the balance, empowering their immune system, and generating, in fact, this phenomenon of memory, as defined by the fact that we then stop the antibody and the patient's immune system remembers that it should be attacking all cells that express these particular antigens, namely the tumor cells, and they maintain these responses. So this durability is one of the very, very exciting things that we have now noted. And this is just looking at the survival curves in melanoma. This is ipilimumab, anti-CTLA-4. This is nivolumab, anti-PD-1. This is now going out towards 3 years. The 20% plateau in ipilimumab actually has been followed out now beyond 5 years. And so the bottom line is that the patients in which we're able to induce these immune responses really maintain this in a stable way. This is the targeted therapy, vemurafenib, that is targeted to the 50% of melanoma patients that have a mutation in this oncogene BRAF. And what you see with the targeted therapies is that they work for a period of 6 months to maybe 12 months, and then the tumors develop resistance. So one of the major differences in the immunotherapies is that because they're not targeting the tumor, they're targeting the immune system, which itself can then learn and adapt. The memory component of that effect gives a durability that you don't get with these drugs. So this is actually the results in lung cancer. When we started with the anti-PD-1 drugs, no one would have ever thought that they would have played any role in lung cancer. But indeed, there seems to be a plateauing occurring around the 20 to 25% level. Now, that tells us that we still have a long ways to go, because when we go to sleep at night, we think about the 80% of patients that we haven't been able to capture by completely training their immune system. But I think it's fair to say that we have made a lot of progress. I think prior to the dawn of this age of immunotherapy, what the world was used to seeing with an FDA-approved chemotherapy or even targeted therapy was a small shift in the median survival curve, but no tail on the curve, no group of patients that ultimately were captured into long-term, multi-year remissions and even potentially cures. What we've accomplished now with the checkpoint blockade has to capture about 15 to 20%, in some cases higher, such as melanoma and kidney cancer, of patients in about maybe half of the different cancer types into this long-term disease progression-free survival. We're still a little bit reluctant to use the term cure, but we're seeing now patients that are out 5 and even 10 years, some of the earliest patients treated with these agents. But where do we want to go? Clearly, the answer is going to be combination approaches that hit the immune system at multiple points to really help that integrated picture that I showed you in one of the earlier slides for all of the components of the immune system to be more strongly empowered to go after that tumor, and ultimately things like vaccines combined with checkpoint blockade and combinations of checkpoint blockers, which are already coming into the clinic to really so-called raise the tail on this curve so that ultimately the majority of patients, even with a diagnosis of metastatic cancer, can be able to truly look forward to having their very own immune systems empowered to keep their cancer at bay, if not eliminate it, for years, decades, and hopefully ultimately the rest of their life. So this is where we're going, and this is where we're very excited that we'll be able to make some very serious inroads.